with. So I decided I'd look at the HIV treatment cascade in children and adolescents and go through the steps in the cascade and what are the barriers and what's new. So just to remind ourselves that there are about 600 new HIV infections a day in children under the age of 15 years, and that was in 2014, and that there are about 1,500 among young people between the ages of 15 and 24. So those are still very worrying figures. And the second big concern is that if you look at the estimated number of deaths among children, you'll see that the only group in which the mortality is actually increasing are the adolescents. So that's a group that's particularly vulnerable and needs much attention. Now, you've heard already about the HIV, in 2014 on World AIDS Day, UNAIDS made a declaration, and the declaration was to have 90-90-90. So in other words, 90%, sorry, I'm getting mixed up with this, between the pointer and the slide, okay. By 2020, 90% of HIV positive children's status should be known. 90% of children diagnosed on HIV should be put onto antiretroviral therapy, and 90% of children who are on antiretroviral therapy should be virologically suppressed, okay? And then if you look at this, the UNAIDS targets, again, we've seen that already earlier. If you look at the number of people who are estimated to have HIV infection, 90% should be diagnosed, 90% should be on ART, and 90% should be virologically suppressed. But the reality is that we're not there yet. There are big gaps in achieving this. And if you look then at the HIV treatment cascade, right, this was first proposed by Gardner in 2011. And this is basically the cumulative effect of the various steps from being diagnosed to achieving viral load suppression. And this is what we're going to be looking at this afternoon, the different steps. So steps are making the diagnosis, linking the patient to care, retaining the patient in care and starting antiretroviral therapy, maintaining adherence, and achieving viral load suppression. This is the cascade of care in sub-Saharan Africa. You saw this already earlier when Connie presented. We have huge gaps and huge decline in numbers from the number of people who are positive to the number who actually achieve virological suppression. And if you look at what they call the breakpoints, these are the areas that obviously need attention, making the diagnosis, keeping the patient in care until you start antiretroviral therapy, keeping the patient on antiretroviral therapy, and then actually achieving the virological suppression. If you look at children, this is actually the only available information currently as far as the treatment cascade in children goes, and this is work done by a group in India, and they published this in 2014. So what they have found was that of the patients who were entered into care, only 43% actually achieved virological suppression. And if you look at this, about half were managed to be retained in care. So we really have a long way to go before we achieve the 90-90-90. So starting with making the diagnosis, it is known, obviously, that if you start antiretroviral therapy early in a child, you're going to reduce mortality, and it's estimated to be at least by 75%. Yet if you look at making the diagnosis, which is the first step, in 2013, only 42% of infants who were born to mothers with HIV in low and middle income countries actually were tested within 2 months of birth. And the recommendation by WHO is that you should be testing at birth, okay? And you can see that Africa, West and Central Africa performs very poorly. East and Southern Africa is not that bad, but obviously it's nowhere near being good enough. So what are some of the barriers and challenges to making early infant diagnosis? Well, there are limited laboratories and clinics which are available to meet pediatric care and pediatric needs. there are many children who don't get a HIV test done after the mom has stopped breastfeeding. And this is obviously one of the risk factors is mom is breastfeeding and child can become infected. And you're supposed to test the baby after the mother has stopped breastfeeding. But this is not being done in a large number of patients. And this is a lost opportunity because you could have tested the baby at that point and linked the baby to care so that they can start the antiretroviral therapy. Another barrier is transportation costs. So we do we test baby at birth, and then we ask mom to come back at 4 to 6 weeks. We do another test. Then the mom comes back at 12 weeks. We do another test. So obviously, mom has to come to a clinic or a center or a facility in order to have these tests done. And of course, they can't always afford to make that number of trips. Then, of course, the stigma and discrimination continue. Some moms simply won't bring their children because they don't want anybody to know that the child might be HIV infected. Then this is an ongoing problem, which we face even today, supply shortages. So mom actually presents at the facility, but they don't have the necessary kits and equipment to do the diagnostic test on the baby. And so it's a lost trip for the mom. It's a lost opportunity for us, and the mother may never bring that baby back to be retested. Then a new problem that has come up now with mothers being on antiretroviral therapy from early on in pregnancy, by the time that the mom delivers, the mom may be very well controlled and biologically suppressed. So the level of, if baby is infected, the level of viremia in the baby may be very low, and we may not be able to pick it up with the current diagnostic tests that are available. So that's a new problem that we're facing. But all is not doom and gloom. We have made some progress and we have some new achievements. We have new tests which are highly sensitive. So these tests can actually pick up very low levels of virus in the baby. A study was conducted in Mozambique, and what they found was that of the babies who were tested at birth, 25% of those who actually tested negative at birth, when they tested them with the ultra-sensitive technique, they were found to be positive. So there is a new ultra-sensitive technique available, and that is being studied, and hopefully that will soon become available more widely. The second achievement is the point of care testing that has been rolled out in many countries and is in the process of being rolled out more widely. The initial studies were done in Malawi and Mozambique, and obviously it decreases the turnaround time for PCR testing. One of the problems with the initial point of care tests was that best results were only achieved in those over 6 months of age, and that's not what we want. We want best results from the time of birth, or at least in the first 4 weeks of life. There's another test that's being looked at, and that's the oral fluid antibody test. And this test actually looks at antibodies. The usefulness of this test is that it helps you to rule out HIV. So in other words, if you get a negative test, it has a negative predictive value of 98%. So it's useful in that it tells you this baby is not infected. Whereas the other way around, PCRs, etc., we're looking for the baby who is infected. And this test is actually very acceptable to moms because you're doing an oral swab. You're not taking blood. You're not doing any finger prick test. There's nothing invasive. So moms in whom this was tested found that they actually liked this particular method and were very happy with it. Okay. And then the next progress or achievement that has been made is the training of lay personnel to do the early infant diagnostic tests. And at the IAS in 2015, this work was presented where they looked at training lay personnel and looking at their ability, looking at the acceptability, comparing the work that they were doing with healthcare workers. And unfortunately for healthcare workers, and fortunately for the population, they actually fared very well. And so the recommendation was that lay providers can safely and effectively perform HIV testing services with the rapid diagnostic tests. Now that obviously would go a long way to assisting in making that early infant diagnosis, because you don't have to depend on a healthcare worker to be able to do that. You can take people from the community, people that are familiar to the community, and they can actually do the testing. In February 2016, last month, the WHO published a fact sheet, which is its regular sort of updates. And the recommendation there is that you should add nucleic acid testing to the existing early infant diagnosis. So we do the early infant diagnosis at birth, and then at 4 to 6 weeks, we should follow it up with more sensitive testing. And together, hopefully, that will give us a better, will give us an improvement in the number of babies that are being diagnosed. And obviously, it will lead to starting treatment as early as possible. The aim, of course, is to be able to start the baby on treatment within that first 4 weeks of life. Okay? And obviously, to that, we would link the baby to screening of the mom, to referral to a center where the baby can be started on antiretroviral therapy, etc. When it comes to adolescents, obviously, there are many challenges as far as testing of the adolescents goes. And from all the work that has been done in adolescents, there are some issues that come up as major barriers for adolescents, and some of these issues are lack of family planning services. So the adolescent doesn't want to go to a center where they can't have a sort of all-in-one, get you tested, get family planning, get their treatment, etc. in one space or one area. There's a failure to provide prenatal HIV testing to young girls, and that came up as a very strong barrier. So young girls between the ages of 12 and 24 felt that when they went to a healthcare facility, the staff at that facility was very reluctant to give them advice and to provide them with appropriate testing. There just seemed to be a sort of negative vibe or negative feeling towards young girls presenting with pregnancy to the facility. So that's a barrier that we need to look at very carefully and see how we can overcome staff prejudice against teenage pregnancies and teenagers requesting testing. Another fact, excuse me, another barrier that came up in these studies was that, again, staff did not want to provide teenage girls with antiretroviral therapy during pregnancy. For whatever reasons, I don't know, but that came up as an issue or a barrier. Substance abuse obviously is a barrier, and we all know that the teenager who's abusing substance, obviously there's not going to come forward to get tested, is more at risk of HIV, etc. So that is a problem, ongoing problem across the world, including in South Africa. Okay. And then there's routine opt-out HIV testing service, where the issue here is, comparing whether HIV service should be opt-in or opt-out, and what's the best of these two as far as teenagers are concerned. So would adolescents be more likely to test if they're in an opt-in service, and in that way you can get more of them tested. As far as the adolescents goes, there is some progress in getting them to be tested, and there are two options that have been suggested for improving testing amongst the adolescents. The one is self-sampling and the other is self-testing. So with self-sampling, the adolescent collects their own sample, blood or of an oral swab or saliva. This is then posted to the laboratory for analysis, and the laboratory then sends them the results. Okay? But obviously that does mean that they have to be identified to the laboratory, and the laboratory has to have a contact number for sending them back the results. Okay? So that to the teenagers is a little bit of a problem or a barrier because it identifies them. The second option is self-testing, where the kit is available and the adolescent can do their own test and get their own result. The problem with that is to get the kit, they have to go somewhere and go to a center or a facility to actually pick up the kit. And that was a barrier for them, because then they would be identified as somebody who might be HIV positive. So there's ways and means of we have to look at ways and means of overcoming this issue of the teenager going to pick up these kits. So can we make these kits available in a place where the teenager doesn't have to be identified? They can go and pick up these kits and test themselves. The reason, the importance of that is that it has been shown that if you make self-testing available, teenagers are the adolescents are the most likely to actually do that self-testing. And it also found that if that self-testing kit was made available in a sort of non-identifiable environment, then they picked up the test kit, they did the actual test, and they returned questionnaires that were given to them with the kits. And obviously the questionnaires were anonymous, but they were more likely to do this test, and they were more likely to return the questionnaires. So that's one of the ways that teenagers could be encouraged to be tested. And they also found that with self-testing, the adolescents were more likely then to go and seek out antiretroviral therapy. Okay? Some of the work that has been done on linking to care and retention, one of the studies that was done in 2012 showed that only 30% of children who were tested were actually referred for initiation of antiretroviral therapy, sadly. So the mom went with the child, had the child tested, but for whatever reason, that baby was never then referred for antiretroviral therapy. There was a study that was done in sub-Saharan Africa in 2014, and that showed that only 12% of mother-infant pairs were actually referred for further care. And that is really an abysmal figure, 12%. Okay? The other thing they have found in this study was that retention in care decreased after 6 months. So if you were not able to keep that baby in your care in the first 6 months and get that baby started on antiretroviral therapy, then your chances of getting that baby onto antiretroviral therapy thereafter decreased rapidly. Okay? And they also found that younger children were less likely to be retained in care. This is a table that looks at some of the studies that were done on barriers to linkage of care in infants, in children, and in adolescents. And there's, I'm not sure how well you can see it at the back, unfortunately, but sorry, this is a bit embarrassing for me as well, because I need to wear glasses to see that. I'm giving away my age, but never mind. I already told you that we saw patients in 1987, right? Okay. So if you look at the last table, right, that looks at the barriers that were identified. So I'm just going to mention them in case you can't see them from the back. So from the South African study, some of the barriers that were identified were poor documentation in the Road to Health card, fear of discrimination, lack of provider-initiated testing. In Zimbabwe, they found that tests were not offered because they didn't have the staff or they didn't have the kits. The guardian that was present with the child was not suitable. And very interestingly is that children who were over 7 years of age, children who looked clinically well, and children who were accompanied by a male relative, or children who were accompanied by younger guardians were less likely to be tested for whatever reason. And the other thing they found was that if there was a male guardian with the child, that guardian was less likely to agree to testing. So those are some of the barriers that have been found in studies that have been done to date. How can we improve retention? Well, some of the work that has been done has shown that if you can get much of your care under one roof, that would go a long way to retaining patients. So if you have a facility, for example, that also provided nutritional support, they were more likely to retain patients. If they linked patients' care to a center where there were people living with HIV and AIDS who attended that center, for example, work that was done in Ethiopia, they found that those patients were more likely to be retained in care. If they had the mother and child facilities under one roof, I mean, that's a no-brainer. Everybody knows that very well, but unfortunately, that's not done. If you can provide all your facilities for the mother and for the child under one roof, you're really, really more likely to retain mom and baby in care. And again, they found that if the facility had a nurse-based health care center and a peer health worker care center, they were more likely to retain patients in care. Okay, so the next step in the cascade, you've made the diagnosis, you've linked the patient to, you've retained the patient and you've linked them to care. You then have to start the patient on antiretroviral therapy. Sadly, the number of children receiving antiretroviral therapy is appallingly low. It was found in 2014 that a mere 24% of children were actually receiving antiretroviral therapy. In other words, 3 out of 4 children living with HIV, or 76%, were not receiving HIV treatment. And we haven't gotten very far from that figure by 2016. We all know by now that early treatment is vital and has been shown to make a huge difference to the pediatric patient. We have the SHARE study, which was done in South Africa, which showed that early treatment makes a difference to the outcome. We have the Mississippi baby. We all know, well, most of us know about the Mississippi baby who was started on treatment very early on in life and showed an excellent response to treatment. Then at the IAS meeting last year, they presented an 18-year-old French adolescent who had been started on treatment early on in life, very early on in life, had stopped treatment after about 4 or 6 years, and had remained off treatment for about 12 years and has remained well. It was that early treatment that they believe had made the difference. And then in adults, you've already heard from Connie about the START trial, which showed that if you start treatment early, you have better benefit. As far as the pediatrician goes, that's an important because of our adolescent population. And then in IAS 2015, again, they presented results from a study in San Francisco, which showed that if you made the diagnosis and you started the antiretroviral therapy on the same day, at that same appointment, it made a difference in terms of outcome. So we know that early treatment makes a big difference. So why aren't we achieving early treatment? Again, there are many barriers and challenges as far as early treatment goes. There are issues which prohibit initiation of treatment in children, and one of the problems is the training of healthcare workers. We do not have adequate training of healthcare workers, and it is only about 5 years ago where we started the training of the nurses. It's about 5 years, was it? Yeah, that we started we scaled up training of nursing staff for treatment of children. There still remains much apprehension when it comes to starting children on antiretroviral therapy. We have suboptimal drug formulations, and we do use non-WHO recommended regimens when it comes to pediatrics, simply because we don't have all the drugs that we would like to have for pediatrics. There are fewer antiretroviral drugs available for use by children. We have higher treatment costs because we have all these syrups and these different formulations instead of tablets. There are issues with the supply of medication. Again, when it comes to syrup, there's always the problem of stability, temperature, transport, storage, whereas with tablets, it's not an issue unless you have very soft capsules. Tablets can be stored and can be transported, etc. Syrups have to be kept stable, most of the syrups. And then again, we have complex formulas, and that can complicate pricing as well. So, you take the individual pediatric drug, this one has to be given so much per weight, and this is the amount of syrup that you have to give, and then you take the next one and the next one. So it becomes an issue, and cost becomes an issue because you have to dispense them individually as well. Right, everybody is familiar with the life cycle of the HIV virus, and I'm not here to talk about the life cycle of the virus. Why I've put it here is to just to show you that, oh, sorry, some of the areas where the new formulations as far as pediatrics goes is in the integrase inhibitors, and then in the new protease inhibitors, new NRTIs, there's somewhere there, anyway. And then not yet in pediatrics, but studies will be underway is the maturation inhibitors, and then there are new fusion inhibitors as well, that again, the pediatric formulations are still to come. So looking at some of the drugs that are available for pediatrics, and of course the drugs I'm presenting here are those that are available for pediatrics, not necessarily in South Africa. We would love to have all of them in the public sector in South Africa, but we don't. But I'm going to put up all of them that are available. But what I really want to highlight is what's in red. So if you look at abacavir, it is now available as a fixed dose combination. So that's a step forward. Emtricitabine is one of those drugs that can actually be used from birth, and again is available as a fixed drug combination. Then tenofovir, remember, was previously only available for from adolescent upwards and from 35 kilos upwards. Right? So the step forward is that it has now been approved for use in children over 2 years of age, and again it's available as a fixed drug combination, so that makes a big difference in terms of medication, amount of medication that the patient has to take. As far as the NNRTIs are concerned, not too much has happened in the pediatric world. You've heard about rilpivirine, which is available for use in patients over 18 years of age, but there is a clinical trial that is currently underway for children from 12 to 18 years of age. Once the 12 to 18 years is done, then hopefully the 6 to 12 year age group studies will begin. A lot has happened in terms of the protease inhibitors. So atazanavir is available for use in patients over 3 months of age, and again it's available as a fixed drug combination. But for me, one of the biggest progresses we have made is that the lopinavir-ritonavir combination is now available as pellets and granules, and that makes a very big difference as far as pediatric goes, because for the little ones, it makes treatment so much easier. The WHO has published a fact sheet in February, so last month they published a fact sheet on the lopinavir, ritonavir pellets and granules. So if anybody's interested, you can go and have a look at it. It tells you about the use of the lopinavir, ritonavir pellets and granules, how to use them, the best way to advise mom to give the pellets and granules to the baby. It also provides you with the doses, the weight bands, and everything that you need to know about its use. Okay. Then moving on, you heard a lot from Connie about the integrase inhibitors. Raltegravir has been available for use on individual patient decisions. So decisions about its use are made on individual patients. Currently, it's only for third line use in South Africa. Okay, so we actually have a committee, and you need to contact the committee if you want to use raltegravir in a patient. Dolutegravir, you heard again about the adult studies. So currently, it's only available for patients over 12 years of age, but at the CROI meeting last month, the pediatric trial, the P1093 impact trial, data was presented for the 6 to 12 year age group, and that of course has shown that it works very well in that age group. And now the study is underway for the 2 to 6 year age group. So that again is good news for the pediatric population. And once the 2 to 6 year study is complete, then they will look at the under 2 year age group. Okay. And then the only thing with the entry and fusion inhibitors, you heard again about Maraviroc, which is available for only for those over 16 years of age. But again, the good news is that there is a pediatric trial which is currently underway. So hopefully we'll have some good news as far as fusion inhibitors are concerned. When we just to remind you, when we talked about protease inhibitors, you notice that most of them require boosting. So darunavir, fosemprenavir, this what here lopinavir is boosted with ritonavir, the tiprenavir, all of these require boosting. And one of the problems with boosting is that ritonavir is available for the pediatric population, whereas the other booster, which is cobicistat, is only available for those over 18 years of age. And currently, as far as I know, there isn't any work that's being done on any other booster for the pediatric population. So we really, really very much restricted here with the ritonavir. There are many new formulations and classes that are currently being looked at. There's been quite a big push because the EU made a declaration to the pharmaceutical companies that they had to show proof that they were doing pediatric studies before they could get approval for the adult studies. And then there's an organization, an NGO known as DNDi, Drugs for Neglected Diseases International, which has made a very big push for pediatric drugs to be available, pediatric antiretroviral therapy to be made available for new formulations for pediatrics, and that has made quite a bit of difference. So we've seen already that pellets and sprinkles and granules have now been developed for the pediatric population. Then you've already heard about the new formulation of tenofovir, so I won't say anything about that. You've also heard from Connie about doravirine, but that we'll wait and see what happens as far as pediatrics goes. And then again, you've also heard about the maturation inhibitor, which only for adults at the moment, but we'll wait and see what happens in terms of the pediatric population. And then the last step in your treatment cascade is the adherence to treatment and viral load suppression. If you look at this table, it shows you adherence levels in several countries and in several pediatric populations. And the adherence level ranges quite remarkably from as low as 25% to as high as 99% in some countries. And you may notice that in some of these, we have the same country twice. And the reason for that is that adherence is looked at in the adolescent population. They look at children who have been infected perinatally through their mums, and they look at children adolescents who became infected through behavior, risk-taking behavior, and they compared adherence in these two groups. And what they have found was that those who are infected perinatally are more likely to adhere to treatment compared to those who become infected through risky behavior. And I think that's pretty understandable, because those with mother-to-child transmission have had the infection for a prolonged period of time. They're aware of the problem. They've become used to this whole setup of going for treatment and testing, whatever. They're more likely to take their medication. Whereas the adolescent that becomes infected through risk-taking behavior, the fact that they get infected through risky behavior means that you're going to have more problems in terms of them taking their medication, adhering to their medication, coming back for their follow-up and their assessments, etc. These are some of the studies that have been done on adherence in children and adolescents. And what we did is we developed a table from taking studies from different countries. So we looked at studies from both developed and developing and middle income countries. And we tried to compare the different sort of problems or barriers that looked at adherence in children. Okay, I'm just going to see if I don't know, sorry. Prinesh, sorry, if you can help me here a moment. There's no way of
make this larger.
Yeah, or clearer.
On screen? No. Over here, yeah.
Thank you. Okay, so if you look at this, So we're looking at this column, right? And that column is factors that promote adherence, retention, and viral load suppression. And as I mentioned earlier, the two studies from the USA which compared the perinatally and behaviorally infected youth, what they found was that with the perinatally infected youth, consistent care, lack of drug abuse, non-African American race, and younger age meant that they were more likely to adhere to treatment and achieve viral load suppression. Whereas with the behaviorally infected youth, the older age group, the heterosexual group, those who had higher education were more likely to adhere to their treatment and achieve viral load suppression. And then things like better quality of life of caregivers, lack of alcohol and drug abuse within the household, family support, youth support, all of those made a difference in terms of adhering to treatment. And then in Nigeria, they established kiddie clubs for children, and then clubs for adolescents and their caregivers. And they found that that made a difference because information that the adolescents received at the club made a difference to their adherence. They were more likely to adhere when they were within these clubs. Also, in these clubs, they were taught about pill swallowing, they were given nutritional advice, they were encouraged to disclose, and they also set up text messaging, and that made a big difference as far as adherence was concerned. And then if you look at some of the barriers to adherence in children and adolescents, they're pretty similar in most of the studies. Fear of disclosure, having to travel long distances, spiritual beliefs, lack of disclosure. And then if the caregiver had multiple jobs, or the caregiver wasn't well, or the caregiver had depression, then obviously that made a difference in terms of treatment in younger children. Currently, that was in 2015, viral load testing was available to 25% of the population that required it in developing countries. At the IAS conference in 2014, the UNAIDS-sponsored Diagnostics Access Initiative was launched. And basically, this was an initiative that challenged pharmaceutical companies to reduce prices for viral load testing, because obviously it's a problem. The viral load tests are so expensive, they weren't accessible to most places, and that's why only 25% of the population had access to testing. In response to this request by UNAIDS, Roche in September 2014 announced a sharp decrease in the price of viral load testing. And as a result of that, viral load testing was then started to be rolled out in several countries in Africa and in Asia and South America as well. So that's a huge step forward. Okay, to finish off, just a few words on the new ARV guidelines that were launched by WHO last year, at the end of last year. And the question was, why do we need new guidelines? Obviously, because we had new science, new studies, new commodities, we had new technologies, and we had to look at ways in which we were managing our patients and what was new and what was working. So as far as pediatrics is concerned, what's new is that option B+ is the only way to go for pregnant women for reducing mother-to-child transmission. All the other options are going to be done away with. Everybody will receive B+, okay? The other new development is adolescent is no more 12 to 18 years, it's now 10 to 19 years, is considered the adolescent period. And again, you heard that from Connie already, antiretroviral therapy initiation at any CD4 count, but you will fast track some of those patients, obviously. And then in children, the new development, remember, you all, those who work in pediatrics know that the WHO recommendation was that if the child is under 5, you start antiretroviral therapy irrespective of CD4 count or WHO staging. The new development is that in the child from 1 to 10 years of age, right? So all children. So from 10 onwards, they become adolescents. So everybody under the age of 10, as soon as you make the diagnosis, you start antiretroviral therapy. You do not wait for the CD4 count or the viral load. So that makes quite a large number of new patients that would be added to those requiring treatment, okay? And the good thing about the new guidelines for children is that you don't have to wait for CD4 count results before initiating treatment in your older child. It avoids any delays, it simplifies the whole process, and hopefully it will improve retention in care because you make the diagnosis and you start the child on treatment. You don't wait to do the CD4 count, talk to them, say come back, whatever. You've got the patient, you've got the caregiver, you've got the adolescent, the child under 10 with the caregiver. You can start treatment immediately, okay? And finally, just a reminder of what's new in the ARV guidelines is we're going to treat everybody under the age of 10, irrespective of the CD4 count. We have this new age band for adolescents. Option B plus for all pregnant women. And they're looking at the possibility in pediatrics as well of introducing the integrase inhibitors into earlier treatment rather than waiting until third-line treatment. Okay. And just to acknowledge my colleagues who worked with me when we prepared this treatment cascade, thank you very much.